Remyelination. We're getting there, one step at a time. But don't just take my word for it. Hello and welcome to another episode of You and Me and Multiple Sclerosis. My name is Pam and I've been living with multiple sclerosis for almost 40 years. And if you've been watching my channel, you know a couple of things. Number one, I've been covering remyelination research and what's been going on there. As often as I see new and exciting things, new and promising things happening, I've been letting you know about them. There's nothing right around the corner that we're going to be able to take advantage of, but there's a lot of research, and at least we can be hopeful that the future does hold promise for remyelination, at least for some of us. The other thing that you may know is that I'm involved in a clinical trial that is looking at the effect of exercise on remyelination. And even though I'm in the control group, I'm not then doing all the exercises. That too is important for the validation of the data that comes out of this research. But you know, I could tell you all about that clinical trial, and I've been thinking I should. But as it turns out, on June 15th, 2024, a number of the doctors in the neurology department at OHSU gave a presentation describing their current research projects. And the lead investigator on the clinical trial that I've been involved in was one of those people. I was not able to attend in person, but they streamed it online, and it's been available since then as a recording. So what I'm going to do is play just the part of that presentation that covers the clinical trial that I've been involved in. The whole presentation, which I really think is worth listening to, is way long. It's about 4 hours long. But I will link it below because it's really worth listening to. There's a lot of really interesting research going on. Just by looking at the agenda for the presentations in this conference, you get an idea of the extent and range of research projects that are going on in multiple sclerosis at Oregon Health Science University. And I am so grateful to live close enough to be able to take advantage of all the knowledge that they have and also to participate in their clinical trials from time to time. And having listened to this, I feel even better about being involved in this clinical trial. So let's go ahead and take a look at this presentation. Well, here's a slide that gives the credentials of Dr. Lindsey Wooliscroft. She's got quite an impressive list of things that she's involved in and has accomplished already. But let's just jump down here to her research interest and funding. That's the last bullet here at the bottom. Rehabilitative approaches to myelin repair. So in other words, not necessarily looking at medications, but looking at physical therapy or exercise or other behavioral interventions that can be done to help with remyelination in multiple sclerosis. That undergirds the clinical trial that she's working on right now, and also the other things that she has gotten involved in.
It is really my pleasure today to really show you what we're doing here at OHSU in order to address some of those outstanding questions about how to promote myelin repair in people with MS, with ultimately the goal of helping restore function for folks with MS. So I'll be discussing today some strategies to promote myelin repair and maybe a few that people can engage in right now. So our objectives will be to basically review now how myelin repair occurs, to review the current status of remyelination therapies under development, and to look a little bit at some of the research in humans and animal models that may support the role of exercise in myelin repair. So first, to review how myelin repair occurs. As we've talked about today, MS is characterized by destruction of myelin. And we can see here you have a healthy neuron with a little cell body here that generates an electrical signal that travels throughout the axon and then goes to the terminus, which communicates with other cells in the brain and spinal cord. And typically you have myelin, which helps insulate the axon and helps electrical signals move faster. Unfortunately, with MS, we have damage to the myelin, as you can see here, and when that damage to myelin occurs, electrical signals don't travel as fast through the brain and spinal cord. So if you have myelin damage in a pathway that affects your vision, you can have vision loss. If it's in a pathway that affects your right arm, you have right arm weakness. And it just depends on where these are located to understand the whole constellation of what we see in any individual MS patient, which is why one person's MS is only one person's MS. And there's lots of different ways that people can experience this disease. This is a familiar slide by now. But as we see, even after that myelin damage occurs, there's a lot of different outcomes that can happen. And as Dr. Emery had showed, sometimes you get poor levels of myelin repair, and sometimes you get more robust levels of myelin repair. And I think it's important to emphasize that this can happen even within the same person. There's not people that only have this level, no myelin repair or myelin repairers, but this can be really different even within the same person. And I also like to emphasize that, with our current techniques, it's really hard for us to know which one of your lesions underwent this repair or didn't. And I'm sure a lot of the names on this will be very familiar to you, but we've been really fortunate in the MS field to have a lot of medications that can actually impact the disease and slow MS disease progression. And I don't think that I spend enough time to really reflect on how cool this is, because if you think about the vast amounts of neurologic disease out there, you have a lot of things that can help you with pain or help decrease seizures, but very few disease states in neurology can actually help prevent the actual disease from progressing. And we know that these drugs don't do everything, and we still need to work harder, but I do want to take a moment just to appreciate some of the accomplishments that we have had, especially since just the early 90s. But while these MS medications prevent relapses, as Dr. Spain had said earlier, they don't help you feel better, and they don't really help with some of the progressive parts of the disease. So what we really want to do is to help you repair your myelin. So again, this is a little figure to summarize some of the things that I think are really essential to myelin repair. And as you see here, you have this little octopus guy. This is your grown-up oligodendrocyte, and he's wrapping myelin around multiple axons in order to help your electric signals work better. And really, for you to get effective myelin repair, you need healthy axons. If you think about this, if you have if you have a toaster that has a cord with it, with a cable, and then with a whole bunch of insulation, where the insulation may represent the myelin and the cord may represent the underlying copper. It doesn't matter how much you wrap a bad cord, you're not going to get that toaster to work well if the cord is just too frayed. Similarly, you need healthy axons that can actually conduct that electrical signals. That way that signal to move your little finger can travel all the way from your brain down to your hand. Also, right around all of these brain structures, there are different things going on that may be saying, hey, let's remyelinate or don't remyelinate. And you really need to have the most optimal environment to keep that myelination occurring. You also need little cells to come in, like these macrophages, to gobble up all the myelin debris and keep the area very clean, so that way myelin repair can occur. We also talked a little bit about these baby myelin cells called oligodendrocyte precursor cells, or OPCs. And I think it's just so cool. They're just like Dr. Emery said, they're 5% of your brain. They're everywhere, even in places that don't have myelin. But we need them to proliferate, and we need to get them to the places where they need to go in order to provide effective myelin repair. And then we need to have them grow up and differentiate to not only be those little OPCs, those little babies, but then to become fully functioning oligodendrocytes that wrap myelin. Now, there also may be some instances where these adult oligodendrocytes can still wrap myelin and they don't have to go through the whole growing up process, but we think most of the remyelination process goes through this period of development. And again, as we sort of alluded to, there's a lot of other cells in the brain that are bystanders, and we used to not recognize how much they impact the myelin repair process, but we also need these microglia and astrocytes to act right and not impede us as we're trying to promote all of this repair. So let's review a little bit about some remyelin therapies under development. And I think one thing that I always like to start off with, because it's such an elegant experiment and it's just so interesting to me, is one of the ways that we identified a lot of the compounds that are currently being studied in clinical trials in myelin repair. And these are called these high throughput screens. So what these researchers did at UCSF is they took a 96-well plate and they put all of these little pyramids on here. So you can see that shown here. And then they scattered lots of little oligodendrocyte precursor cells all around them. So each of the little pyramids had an oligodendrocyte precursor cell that was associated with it. And then in each of the wells, they put a different drug that was FDA approved. And then they watched basically that well to see if those oligodendrocyte precursor cells grew up to become full oligodendrocytes, and then if they wrapped myelin around those little pyramids. So you can see here, basically the black circles represent little pyramids that, nothing happened and the baby cells died. But you also see some where the oligodendrocyte precursor cells lived and divided, shown here in green, or some where they developed into mature oligodendrocytes. And they could also look at the thickness of the wrapping of the myelin to see if some were better than others. So it allows you at a single time point, look at a lot of drugs, see how they work, and compare one against the other. And so they were able to look at 500 FDA-approved medications all at once. Because as you can see here, to take a medication from animal models into the bigger trials with people takes decades. So if we are able to look at lots of medications that are already FDA approved, that means that we can get drugs to you faster and we can start those clinical trials even quicker. You can see here, we highlight a few of them that were the highest contenders, and you'll recognize clemastine here. And because it promoted the most differentiation and it had the thickest myelin, that was why it was taken into a lot of the clinical trials that we talked about earlier. Again, I think lots of caveats with that one. It's a very dirty version of like a Benadryl, so it has a lot of sedating side effects, could also contribute to memory loss if taken long term, so not necessarily something that I'm encouraging patients to go out and try, but again, it might be a good test case to start understanding a little bit more about what remyelination can do in clinical trials. Some of these other drugs are also ones that we use for different bladder issues or antipsychotics, et cetera. So, that's really nice that we were able to identify some candidate medications, but we really need to know how myelin repairs occurred in people with MS, because like I told you, when you get that yearly MRI in our clinics, we can't look at it and say, well, this lesion repaired well and this one didn't. And so we need to have better outcomes to use in clinical trials. So some of this is a little bit familiar from Dr. Silverman's talk about visual evoked potentials. But one area that we look at is looking at functional remyelination outcomes. Like we talked about, myelin helps electrical signals move faster through your body. So presumably, if you have a lot of myelin and a lot of insulation for that electrical signal, electric signals move faster. And you can look at different systems in the brain if you stimulate the system and then measure it at another time point. So the visual evoked potential is, just as a review, is the one where you look at like a checkerboard, a moving pattern, and then you measure the resulting electrical signal at the back of the brain to see if there's any slowing anywhere along the visual pathway. But another area that's rather interesting, because as we know from Dr. Cameron's talk, the sensory system is involved in falls and in many of the things that are important to our MS patients, is that we can also look at the somatosensory evoked potential, where we give an electric stimulation, either in the legs or in the arms, and then we can see how fast that signal moves to stickers or electrodes that are put on the scalp. And you can see how fast that signal moves from your leg to your brain. And presumably, again, if you get remyelination, those signals move faster and faster, and they're more efficient. But we can also do very fancy MRIs that use a lot of different techniques. And this highlights some research that we did in a small group of patients, just to show you a little bit about one of those techniques, which is called quantitative T1 relaxometry, which sounds very smart. But we took patients who had brand new MS lesions. So you can see here, this is what your neurologist may show you on your traditional MRI, where you have new lesions that took up the contrast dye that probably happened within the last 2 to 3 months. And then we imaged them right when they were having an acute attack, and then 6 months later. And what we found is that, if we image brains of healthy controls using this technique, we see their myelin water fraction, or their myelin content, is pretty high. It's up here. But in MS, even the brain parts that looked normal had slightly less myelin than what we see in people without MS. But if they got a new lesion, those areas, the myelin went down quite a bit, but after 6 months, it recovered to about the same area and about the same myelin content as lesions that had been there for years. So that shows us, at about the 6-month mark, that myelin can recover and that we can measure this pretty reliably. I think the other thing that we have to figure out is how to measure those remyelination outcomes and see how that affects you. And I think the problem is that's still a really outlying question. As you can see here, I think a theme is that, we have ways that we measure this in clinical trials, but it doesn't always reflect how you are feeling. And I think that we really need to make sure that any of our clinical outcomes reflect your quality of life and how, you are living. So we've talked about some of these factors, but I think it's worth going over what may influence remyelination potential in each person with MS. As Dr. Emery said, it could depend on the age of the person, and thus the age of those progenitor cells. There's also an influence of biologic sex and hormones, and there are several trials going on right now. They're looking at different hormone therapies to see if they can also affect remyelination potential in MS, because we see things like pregnancy can be protective for people with MS, and sometimes perimenopausal or postmenopausal states can hurt, especially women with MS. We also see that there could be a difference in MS subtype. Especially if you're in the progressive stage and you have more degeneration, it may be harder to wrap myelin and have effective remyelination. And it may be harder to do that if you've had MS for longer. It also may depend on the amount of lesion damage. Oftentimes in our clinical trials, it's easier for us to detect that you've had remyelination occur if you have more myelin damage. And that might just be a reflection of our techniques to be able to measure this. It also seems like there could be some difference in lesion locations. So some lesions repair better than others. So some of the deep parts of the brain can remyelinate a little bit better than some other locations. So location may matter where that injury is. There's also an influence on the inflammatory milieu, which is just a fancy way of saying, how much inflammation is in your body. So we think that people that are on a more highly effective MS medication have less inflammation in their brains, and that sets up a better environment in order for repair to occur. It can also be influenced by other medications. As you can see, we screened several medications to see if they could help repair myelin, and maybe some of those have an effect on you. As Dr. Silberman talked about, there could be other vascular factors. We see people with uncontrolled high blood pressure or cholesterol can have worse MS courses. So perhaps your other medical issues may make you a better or worse repairer. But I also think that there's a lot of potential lifestyle and especially physical activity and exercise, which may influence this process. So now we'll review the research in humans and animal models of MS supporting the potential role of exercise in myelin repair. And again, this is a familiar slide, and I won't go through all of the data that supports this, but from what we know in animal models, we see that exercise may affect multiple parts of this process, shown here in red, including optimizing the microenvironment, helping OPCs proliferate, and help them grow up to be oligodendrocytes. And I'll just spend some time on one animal model study, which I think illustrates the potential role of exercise really well. So what they did here is they took mice, and as Dr. Emery alluded to, there are a lot of different ways to give mice a condition that resembles MS. This one used a model called cuprazone, where they basically, cuprazone is a chemical that can induce demyelination. And then they watched them to see how well they remyelinated these structures. And here you can see basically some pathology slides where they cut up the mice brains, and then they looked at the amount of axons that got remyelinated and versus the ones that stayed unmyelinated. And basically green is good, so green shows remyelinated axons. And you'll notice that that was in the group of animals that were allowed to exercise on a running wheel. And then they compared that to a group of animals that were not allowed to exercise, so the control group. And what they found is that the exercisers repaired 87% of their axons compared to only 50% of the controls. And what's really exciting about this study is that, they saw some promise with exercise, but then they also asked, well, how can we combine exercise with potential remyelinating medications? And so, like I said, clemastine is one of the top contenders for having potential remyelinating effects. And so they took a group of mice, and one group of mice was not given any clemastine and was not allowed to exercise. One group was just given the drug clemastine. One group was allowed to exercise. And then one group was given both clemastine and exercise. And what they found is that the combination group had more oligodendrocytes than either exercise or clemastine alone, though notably clemastine and exercise performed fairly similarly. And ultimately, clemastine and exercise both remyelinated about 85% of axons, whereas the combination of the two therapies remyelinated 98% of axons. And another thing they did is to look at the myelin thickness, because it's not just enough to wrap myelin. You need good quality myelin in order to get those electrical signals to move. But they also found that the thickness of the myelin was better when you combine the two therapies. So that came out in 2018, right around the time that I was writing my research award, and I thought that this was exciting enough. Like, why don't we look at this in people? So I'll spend a little bit of time looking at exercise in people with MS. So people with MS are not unique. They need the same amount of exercise as anyone, according to the American Heart Association, which turns out to be about 150 minutes a week of exercise or physical activity. But unfortunately, less than 20% of people with MS engaged in the recommended amounts of physical activity. And, it's not to call out anyone with MS. I am actually listening as I'm typing your notes. And I know how hard things are. You're suffering with fatigue and heat sensitivity and a lot of mobility issues. And so it can be very hard for people to engage in the recommended amounts of physical activity, which is difficult because, exercise really does benefit people with MS. We see that if you engage in really vigorous physical activity in your teens, it reduces the risk of development of MS. And in clinical trials, if you pool lots of people who've been in exercise groups versus control groups, it decreases the relative risk of relapse by 27%. Just for context, some of our even our first MS medications like glatimer or Copaxone or interferons, Avonex, that class of medication reduced the relative risk of relapse by 33%. So this isn't nothing. We also know that it improves walking speed and it helps you walk longer. It's one of our only proven therapies for fatigue. It improves depression. And we aren't clear if it helps with memory and thinking, mostly because this is not the primary focus of a lot of the exercise research. It's usually just a side question. But I think just anecdotally, I feel like it likely does. So what I really wanted to understand is if exercise repairs myelin, and if so, what are the best forms to do it? How much do you have to exercise and how long? Especially when, I understand that people with MS are operating with a lot less energy. And, I really think you have to donate that to what's really going to help your quality of life. So we're currently conducting a clinical trial to see if exercise repairs myelin and improves MS symptoms. So what we do is we use that somatosensory evoked potential that we talked about a few slides back to see if you have enough damage in your sensory system. And if you have enough damage that we can actually measure repair, you enter into our clinical trial where you're randomized to either an exercise group or a control group. So in our exercise group, we have a recumbent bicycle delivered to your house. And we ask you to exercise 3 times a week. This is like a 5-minute warm-up and then 30 minutes of pretty vigorous aerobic exercise that we slowly get you into. And it's based on your maximum heart rate that we determine with an exercise test. And then we give you a little chest strap and then have you connect that to a Wahoo app, which is used mostly for cyclists, but can measure the minutes that you spend in each heart rate zone. And then we encourage you to do some kind of cool down or stretch. And so we get on the phone with you and we exercise with you 3 times a week for the first 4 weeks. Then we're on the phone with you 2 times a week, and then we let you do it on your own 1 time a week. And then we have 1 supervised and 2 unsupervised sessions for the rest of the 24-week or 6-month trial. And that's compared to an education control group where we have monthly 60-minute group visits where our participants talk about different MS symptoms with other MS study participants. And then we have study visits here at the baseline where they get screened, and then at 12 weeks, and then 24 weeks. And so here are a few demographics. So just basically information about the people who have enrolled in our study thus far. So most of the people that we have are in their mid-40s. Like general, patterns of people with MS, they're mostly women. And most of them have relapsing remitting MS for about 10 to 11 years. And they're mostly people who are less debilitated. And they're on a variety of different MS medications. And as you can see, I have demonstrated here phase 1, or all the people that we screened, versus phase 2. Those are the folks that have actually entered into the clinical trial. And then we have another subset of folks who underwent an optional MRI. So that's the farthest column on the right. And we've been really lucky. I think that our participants, they just inspire me every day, like not only in my career, but also to get on my own bike, because they've been remarkably adherent. We've had 12 complete the study, and a few are currently enrolled, but they've attended 83% of the sessions on average, with only 2 dropouts. And if you think about a 6-month exercise routine, I think that's pretty impressive. And in our control group, it can be disappointing, obviously, to join a study and be in a control group, but they have also been just the most dedicated folks. And a lot of them completed the trial and also completed about 88% of the sessions on average. And again, this is very preliminary data, so we still have to analyze the whole cohort. And we hope that these trends hold, but we don't know that for sure. So there's a few caveats to this information, but I was really excited about it, so I really wanted to share this with you. Because of some very generous donors to the OHSU Foundation and the Laura Fund, which honestly all of us have benefited from in one way or another to really further our research goals, we were actually able to look at some of these very fancy MRI techniques in a subset of patients to see if myelination was occurring. And it has impacted my work in so many ways that I don't even have time to describe here. But we were able to look at the MRIs right at the beginning of the study and then 6 months later. And we looked at the change in the myelin content in this area of the brain called the thalamus, which is a really important relay station for pretty much everything. It's involved in fatigue, cognition, sensation, motor. It's a railway station to the whole rest of the brain. And it's also one of the first areas that can remyelinate the fastest and the most robust in some of the other clinical trials that I showed. And so you can see some of the changes in that myelin content in the exercise group here in blue and the control group here in orange. And I just show this, I know it's a lot of different lines, but you can already sort of see that people who weren't changing their exercise routines, most of them stayed about flat over 6 months or had some decreases, while you can start to see a trend where the people who were exercising were starting to increase their myelin status. And what was really exciting to us is that we correlated this change in the thalamic, or this change in myelin content, with a percent change in VO2 max, which really measures any changes in aerobic fitness that they had. And again, the control subjects are here in orange, and the exercisers are here in blue. And we are seeing that, the people who had the biggest changes in their aerobic fitness, the people who got the fittest, had the biggest changes in their thalamic myelin content. And I know we talked a little bit about how as we age, that remyelination potential is less. But what really jazzes me about this research is that some of the people here, because it may not be any surprise, but I think the older folks were a lot more dedicated, and they did exactly what we wanted them to, and they got really fit. And these were people who were in the 55 to 60-year-old age range. They really got a lot fitter, and they had some of the more impressive results, even compared to some of our younger participants. So perhaps there's something where we can change the metabolism by making you healthier, making you more aerobically fit, working on those blood vessels that Dr. Silverman talked about, that really can change that capacity for repair. And then, unlike all these other drugs that are going to take decades to come out to you, any amount of exercise, we don't know. Any amount of exercise may be able to do this. Even if it doesn't change your myelin, it can help with all those other symptoms that we talked about. So again, I'm a big preacher of aerobic exercise and those kind of lifestyle changes, but even more reason to eat your salad and then go for a walk and really work on the other components even beyond the MS medications that we talked to you about in clinic. Again, kind of a reason why I do what I do, this was one of our participants in the exercise group, and really, to me, demonstrated some of the benefits of exercise when he told us, I'm an avid outdoorsman. Hills that I used to struggle to climb are now easy. While it is still an open question if exercise can repair myelin, I know that it improved my functioning and quality of life. And again, I just wanted to make a little plug too for another trial that Dr. Silberman talked about, where we're looking at sensors and these very fancy OCT machines. Because I know my study was with very mildly disabled people, but we know that anybody who uses a cane or a walker, they're not included in any of these MS drug trials, because we really can't tell as easily how well they get, because at least on our primary outcome measures for MS, if you have a cane, you have an EDSS of 6, but we know that, just because you use a cane, you can have good days, you can have bad days, and this can be affected by a lot of different things that can vary day to day. So what we'd like to do is to figure out a way to have a sensor strapped basically to your lumbar spine that you would wear, not strapped, it's like a belt, but you would wear this belt for about 7 days, and it would actually look at more nuanced metrics of your walking. So that way we can see if your physical activity increases, how well your gait is doing, and be able to look at that for a longer period of time to really be able to tell your quality of life and your activity levels. And we were specifically focused on people who use some kind of walking aid, because if we think that if we can show that these outcomes are good in these populations and really show a difference, then these can be good clinical trial outcomes for future studies. So if you would like to participate, please email msresearch@ohsu.edu. You can also, we have a sign-up sheet with this handsome gentleman in the back, waving his hand. And also, if you would like to participate in any other studies, feel free to email this email address, and we'd love to tell you about the ongoing and future research studies that we have here.
Well, what I really appreciated about that talk was the focus on non-pharmacological interventions that also play a key role in remyelination and just general improvement in the quality of our lives. So often with research, we tend to think that, oh, it's sponsored by pharmaceutical companies because they're trying to discover the latest and greatest new drug that everyone's going to be taking, and it's going to make them scads of money. And while I don't really begrudge them making money if it makes my life better and the life of other people with MS better, it's still nice to know that other things besides pharmacological interventions are being looked at. And exercise is something any of us can do. You don't need a gym membership. You don't really need expensive equipment even. You can do the simplest things because any movement is beneficial. That's what I keep hearing, and that's what I've been practicing as best I can. Some days better than others, of course. We only have a certain amount of energy in a day, and I know that there are times when we make the conscious decision to save that energy for a particular thing that we know we want to do. We don't want to spend that energy on something that it might benefit us, but it's not going to be the thing that brings us the most joy in our day. And joy in your day, very important, right? But leave me a comment about this presentation. Tell me what you think. Is this a clinical trial that you can see benefit in? Is it something that you could be interested in being involved in? And clinical trials in general, what might interest you in being involved in a clinical trial? What might make it a definite no for you? I would love to know. But that's all I have for you today. So until my next video, please do take really good care of yourself. And I'll see you again soon.